All right, well, thank you so much for having me today. I love talking about the skin, and as a medical dermatologist, this is one of my favorite topics, skin signs of internal disease. And so I'm going to present you all with several cases. I want to make this very applicable for what you all see and provide some updates in the literature. Okay, so I have no disclosures. I am an author for Up to Date, and I'm on the editorial board for JAMA Derm. So my objectives today are to recognize skin findings that herald systemic disease, help you evaluate these patients, and also increase your knowledge of medications that can cause these cutaneous and systemic inflammatory disorders. So rashes, which is going to be my focus today, can be very hard, and they can often make you all and dermatologists feel like my 4-year-old son when he's having a temper tantrum. And so I want to make these moments less frequent for you all and also let you know that if you have a complicated patient, just call us. I love to see these patients, and we learn a lot and can make patients better. Okay, so my first case, this was a patient who presented to me with new bumps. He was 33, and he had this sudden explosion of bumps all over on his back, buttocks, knees, and elbows. Occasionally tender, totally healthy. He did drink and smoke, not on any medications, no diagnosed medical conditions. And this is what he looked like. So this is his shoulder, and this is a close-up view. Okay, so I want you to make a mental note of what you think he has. Does he have folliculitis, molluscum, secondary to underlying undiagnosed HIV, a Langerhans cell histiocytosis, eruptive xanthomas, or acne? So just kind of think about what you think it is. And so this patient has eruptive xanthomas. And just as a further information, he was actually referred to me by his PCP for folliculitis and had failed cephalexin, okay? So just to show you, we'll go over pictures here to compare, but these patients, I've actually seen this several times, present with very rapid onset of these erythematous yellow papules. It loves the extensor surfaces, but it can be all over, and they can be in the hundreds to thousands, and they often have a red halo. So just to compare here, let me see a mouse. Here it is. Okay. Well, maybe not. Okay. So on the left, oh, here we go. So you can see that these are very yellow. Oh, missed the question. So these are yellow bumps, and they have a red halo, versus molluscum on the top right, which we see a lot in dermatology, and I know you all see in primary care. These are pearly umbilicated papules. They can be very red, but you would not expect them to have that yellow look. And then on the bottom, we have folliculitis, which is very common. But what you have to remember about folliculitis, it's around hair follicles, which these eruptive xanthomas are just scattered diffusely. And they can be, folliculitis can be pustules or they can be papules, but they're around there will be a central hair follicle for those patients. And so with these patients, what can be elevated? Hopefully you all didn't see the right answer. Chylomicrons, VLDL, LDL, LDL and chylomicrons and VLDL, or all of the above. All right, so I tried to trick you by throwing in the all of the above, which is not the right answer, but it's actually chylomicrons and VLDL. And so this is a disorder of triglycerides. These patients typically have 1,500 or higher in their triglyceride level. And this can happen with hereditary dyslipidemias, type 1, type 4, and type 5. But it also can happen with acquired and very poorly controlled diabetes, nephrotic syndrome, obesity, hypothyroidism, and even some medications. And some medicines we prescribe in dermatology can actually cause a significant increase in triglycerides, and we have to watch for this potential side effect. And their serum can look like this from such significant elevation of their triglycerides. And so this patient's labs that we got, this is what it showed. A glucose of 400, over 400, cholesterol of over 1,000, and triglycerides of 11,000. So pretty impressive. And this guy had no abdominal pain, no other symptoms, clearly no medical history, right? He's healthy because he hasn't been to a doctor in a while. And so what did I do? I called up his primary care provider, said, all right, well, I'm going to hand this back to you. We've got a serious issue here. And this patient shockingly did not have pancreatitis, at least at that time. But we really have to do rapid management of their diabetes, their dyslipidemia. And these skin lesions actually go away as quickly as they appear with treatment of their underlying condition. So this is something to watch for in your clinic. It's actually more common than you would think. So I've seen it about 3 or 4 times in the last few years. So just to show a couple other things, on the top left, I'm sure all of you have seen this in patients. This is a different disorder. These are called xanthomas. And these patients actually 50% of the time will have an elevated LDL. So this is a cholesterol issue and not triglycerides. But 50% of the time they have no abnormality. I probably see this once a week in my clinic. So if someone presents with these and they're less than 50 and they have family members with the same thing, you do really want to screen them for a genetic dyslipidemia as well. And the picture on the right is a more rare condition. This is called necrobiotic xanthogranuloma, and you could maybe see how someone could confuse these two as the same thing. But this is more orangey yellow plaques. It's not that homogeneous yellow, and it's also on the inferior eyelids and not just the upper. And 80% of these patients have a monoclonal gammopathy or a lymphoma or a leukemia. So this is actually something that, if we diagnose this, can really change the patient's life and save their life. So with these patients, we do a full exam, workup, review systems, coordinate care with their primary care, and do imaging, even bone marrow, et cetera. So just something to think if you see someone with things around their eyes, okay? All right, moving on entirely to a different rash. This was a patient who was 43 who showed up for a rash after a sunburn from playing golf. You can see her medical issues and all of her medications that she's on, which is quite a list. And this is what she looked like. So you can see her hands, you can see her eyelids there, her arms, and then another photo. Okay, so what is her diagnosis? Is it a photosensitivity to a medication that she's on? Is this some type of contact dermatitis, dermatomyositis, or systemic lupus erythematosus? So dermatomyositis is the right answer. So these patients present with these erythematous papules over the knuckles. You can see they're not as obvious in her, but she's got this erythema around the nail folds. And then we call that the heliotrope sign when you have a redness above your eyelids. Lupus tends to be the butterfly rash with sparing of the nasolabial folds. And this condition can also be caused by medications. So what is the most common drug that can cause this? Calcium channel blockers, hydroxyurea, statins, hydrochlorothiazide, or proton pump inhibitors. And so probably most of you have never seen this, but hydroxyurea is the most frequent cause. We obviously use it much less often, but calcium channel blockers and statins and PPIs have all been reported to induce dermatomyositis, and a lot of patients are on those medications. I'm going to talk about HCTZ here in a second. This was actually a large review of all the different cases of drug-induced dermatomyositis. There's a long list. Atorvastatin was the most frequent associated drug, and then PPIs, and there's a long list there, and it's expanded since then. So patients with dermatomyositis, they can have proximal muscle weakness. We don't know the cause. It's an inflammatory condition of the skin and muscle. It's photosensitive distribution, but they can also have internal involvement with their lungs, their heart, esophagus, but 25% of the time these patients have no muscle involvement. And it is thought to be in some patients perineoplastic. So studies vary. The standard incidence ratio is about 3 to 6. We do know in women that ovarian cancer is overrepresented. So all women need to have a pelvic ultrasound and any age-appropriate screening. The highest year after diagnosis is the highest risk, but it actually remains elevated for up to 5 years post-diagnosis. So these patients need to be monitored very closely. So this is just an even more prominent heliotrope rash on the eyelids and just this erythema on the face. This is another patient of mine. This is a teenager who I follow. When she presented to me, she had the very classic Gaucher sign, Gaucher papules, and you can see that the erythematous plaques are over the joints. They can extend in between, but that's the prominent location. And she also thought that her nail issues were from manicures, but she has that erythema and those raggedy cuticles there in her chest. So the patient that the first patient, she actually went on to develop shortness of breath. She had a further evaluation, was diagnosed with interstitial lung disease. Care was coordinated with a pulmonologist, and she was put on high-dose prednisone and mycophenolate mofetil, 3 grams a day. So this is a more recent update in the literature, and you all may not have heard of this antibody, but this is which antibody is associated with dermatomyositis and rapidly progressive interstitial lung disease. JO1, Me2, MDA5, and TIF1 gamma. So I think you all have probably heard of JO1. MDA5 is the correct answer, but anti-JO1 has been known about for a while. It's associated with anti-synthetase syndrome, and these patients can have interstitial lung disease, not typically as rapidly as progressive. Me2 is our very classic cutaneous dermatomyositis with the Schadt sign, very good prognosis. TIF1 gamma has been recently described in the last 5 years, and if patients have this antibody, they have a very high chance of having a cancer. So this is the synthetase syndrome where they have these mechanics hands. This is our Schadt sign with classic dermatomyositis. So MDA5 has been more recently described initially in Japan and then also in the States. Patients who have this antibody were found to have a prognosis of about 6 months because they developed such rapidly progressive interstitial lung disease. So this is actually a very concerning feature. And in this patient, she actually came in with a worsening skin eruption a few weeks later despite being on treatment, and actually had ulcerations of her skin and these kind of odd erythematous papules on the palmar surface, and then actually an ulcer of one of her Gotrin's papules. And so there was a large series of patients out of California that was published at Stanford, and they actually found that patients had this antibody have some additional clinical signs that can help us, such as skin ulceration, these palmar papules. These patients do not have muscle disease and this rapidly progressive interstitial lung disease. And so unfortunately for this patient, and this was before the testing was available, but clearly her course was severe, and she was actually doing well and was visiting relatives out of town and actually got like a virus and actually was admitted to the hospital and died shortly thereafter. So her course was similar to the other patients who have been described with a prognosis of about 6 months. So something to be aware of with the skin. And then I'm going to talk about some other drug-induced eruptions because these are common. This is not as common, but some of the other ones we'll get to. So with a lot of these new agents that we're using for metastatic melanoma and other cancers, a lot of them have been associated with new autoimmune conditions presenting in the skin. And most recently, ipilimumab, which we use for metastatic melanoma, has been known to cause dermatomyositis. So this is a series of patients. And you can see this redness on the face and on the chest. And then this is another drug rash that we can see, or another rash that can be caused by a drug. And so with these patients, you can see this is not that diffuse pattern like the Schadt sign, but it isn't a photodistribution. These are kind of red and scaly, and you could almost mistake this for psoriasis, possibly. But this is actually subacute cutaneous lupus erythematosus. So this is a patient that I followed as well. So SCLE are more psoriasis-like or scaly on sun-exposed areas, but one study actually showed that up to 1/3 of cases are thought to be from medications. And the most common cause is actually hydrochlorothiazide, but also ACE inhibitors, calcium channel blockers, PPIs. So that takes off a lot of very common medications. Fortunately for a lot of these patients, if you stop the medicine, it can take up to 3 months, but their rash can resolve, and then you know it was the implicating factor. But it can be very challenging for patients on numerous medications to know which medicine is the cause. The Roe and Law antibody will also disappear in many of these patients. And then just another little update about HCTZ. So we know it can make everyone sensitive to the sun. It also can cause SCLE, but there's actually a study that's in publication right now that it increases your risk of non-melanoma skin cancer. And they actually, it was a Danish study of over 80,000 patients, and they found that patients on high usage, which was equivalent to being on it for about 6 years, had a significantly higher risk of squamous cell carcinoma in the skin and also basal cell, but it is dose-related. So something to be aware of, add to our list of things we need to tell our patients to watch for, but if you're prescribing HCTZ, just reminding them to be cautious and also have a good skin check. All right, we are changing gears again entirely to a case of bumps that someone presented to me with. This was a 32-year-old African-American woman who came in for new bumps on her arms and hands. She actually had several tattoos placed a year before, and many months later started noticing these bumps appearing within the tattoos. They itch and burn, and they're enlarging in size and number. Past medical history, she has asthma. Here are her medications. Former smoker, she's otherwise feeling fine, just has these skin lesions. And this is what she looks like. And this next picture is my favorite because you can see there's 2 bumps in the eye of the tiger there. I really liked how it just kind of made my OCD happy that it was in both eyes. So, and then another lesion here in the little claw. Okay, so what do we think? Oh, this is the biopsy. Lots of stuff in the skin, basically. I'm not a pathologist, but there's lots of stuff going on here. Okay, so what is her most likely diagnosis? Did she get an atypical mycobacterial infection from the tattoo placement? Is this sarcoid? Is this a foreign body reaction? Or is it just a lymphoma that just happens to be in her tattoo? So this patient actually has sarcoid. So actually when I biopsied her and got the results, she was like, oh yeah, I had sarcoid like a while ago. It's been a long time. It's been in remission. I forgot all about that. So then she started to develop, so she had been treated many years before, and then she actually then started to develop lesions that were not just in her tattoo. So you can see these on the face. So sarcoid, it's a multi-system granulomatous disease. We know there's increased cell-mediated immunity, and there's compartmentalization of these monocytes and T cells forming these granulomas worldwide. It's highest in Sweden and the United Kingdom, but in the incidence, it's African American women in the 4th decade here in the States. We do not know the cause. Some have proposed autoimmune etiology. They've actually been able to identify some mycobacterium DNA sequences from sarcoidal granulomas, but they've never been able to culture it. We also know there's a genetic susceptibility as well with certain HLA types. So any organ system can be involved. And 10% of these patients do have hypercalcemia, and that's because the actual histiocytes in the granulomas actually make calcitriol, which is interesting. So skin, 25% of the time, these patients will have involvement of their skin. And they can look like a lot of different things. Her lesions, I've seen a lot in sarcoid, the very dermal kind of shiny papules and nodules. They can be reddish brown. They are often symmetric, and they do favor the upper extremities, but they can show up in scars and in tattoos. We do not know if someone shows up with just skin, what their chances are of getting internal involvement. There is a small study of just 8 patients where they followed them, and 3 years later, all 8 of those patients who only had skin initially had developed systemic disease, but we really don't have any other studies to look at that. So some of the many faces of sarcoid, it can actually look like a rosacea, even a lupus type picture. It can be more of just a bright red diffuse rash. It can be on the nose. We call this lupus pernio. It can actually cause scarring alopecia, be hypopigmented, ulcers, even nail dystrophy. And this was a patient of mine who had more annular lesions on his forehead, and he actually also had this on the leg, and both of these, when you biopsied it, were sarcoid, which is just fascinating that they look completely different. This patient was being treated for pyoderma gangrenosum, but this was actually sarcoid. And this is a different patient who had these kind of just red telangiectasias on her feet, and when we biopsied him, it was actually sarcoidal granulomas. Another patient of mine who has these annular scaly plaques. And we know that erythematosus can present in sarcoid. These lesions, if you biopsy them, are just inflammation, but they can also have a different form where they actually have sarcoidal granulomas in the subcutaneous tissue. And this was a different patient of mine when we biopsied this. This is actually all sarcoid. So it can be very interesting in lots of different presentations in the skin. So when we see a patient, we really do a full evaluation. You want to evaluate their lungs. You want to get lung studies. You can't forget the heart with EKG, eyes, blood work. If they have any involvement of their nose, it's actually really important to see an ENT because we know there's a higher risk of upper airway involvement. And then the ACE level. ACE level is actually pretty controversial. It's elevated in about 75% of patients with untreated disease, but it's very low sensitivity and specificity. And there are actually other conditions where they can have an elevated ACE level and give us a false positive. So diabetes, Hodgkin's, TB. And use for monitoring it in disease is really unclear, so I don't usually check this because if I have a biopsy clinically, I don't think this changes my outcome for these patients. But it's something to be aware of because it is ordered frequently. So treatment, we have lots of treatments as well. Localized disease, I often just do injections, but we do antibiotics, antimalarials, even adalimumab. Some of the biologics can work for these patients. Etanercept, ironically, can make it worse or cause it, while adalimumab can make it better. And it's just their mechanism of action is a little different, which is really interesting. And so with this patient, she had some mild lymphadenopathy, but upon further workup, really didn't have any other involvement. We did do a trial and error of lots of different treatments, and ultimately she was on adalimumab and was lost to follow-up. Okay, moving on again to a totally different rash. This is a 51-year-old white man who came in for a 5-month history of an itchy rash in his groin, buttocks, legs, and arms. He had had some response to repeated IM Kenalog or triamcinolone injections from his primary care provider. Past medical history, he did have untreated hepatitis C, hypertension. Here are his medications. Other than this rash, he reported feeling fine. Elbow, knees, and his buttock. Closer up view there. All right, so what do we think the diagnosis is? Dermatitis herpetiformis, vasculitis secondary to hep C, contact dermatitis, or Henoch-Schönlein purpura. So he actually has dermatitis herpetiformis. So this is an extremely itchy rash that shows up on the elbows, knees, extensor surfaces. It also loves the buttocks and the groin. We know that it is a gluten sensitivity in some genetically susceptible individuals. Northern heritage men are more likely at risk. And patients ingest gluten and actually develop antibodies to the gliadin, and then you get immune complex deposition and they form the blisters in the skin. So if you go and do a biopsy of the small intestine in patients with dermatitis herpetiformis, 90% of them will have an enteropathy. But most of them do not have GI symptoms. They may have minimal symptoms and it's really focused in the skin. And they call it herpetiformis because these lesions are grouped together in a cluster. So we think of herpes, they're clustered. These are also clustered vesicles or papules. You can have petechiae, which this patient had on his buttocks, which was a little interesting. It's more commonly seen in children, but it can be seen in adults as well, and is another cause of ulcers in the mouth. So this is more of your classic with the knees. And often you're not going to see a vesicle because they have just scratched their skin and they're not going to have anything intact. Usually it's just erosions and excoriations on the knees and elbows. And then here again we have the buttock area. But you can see he has these little clusters of these petechiae actually. And you think about vasculitis being in your weight-bearing areas in your lower legs is where it starts. So when you biopsy these patients, they actually have splitting at the epidermal-dermal junction and these neutrophils accumulating. And when we do a study called a DIF, you actually get IgA deposition in the skin. And so these patients, like a lot of autoimmune conditions, are at high risk for other autoimmune conditions, specifically autoimmune thyroid, up to 11%. So all patients should have their thyroid screened. They can also have Addison's, type 1 diabetes, and then the celiac disease we know has a risk of non-Hodgkin's lymphoma, and it's thought that long-term adherence to a gluten-free diet may lower that risk because you're not having chronic inflammation in the bowel. So what is the gold standard test? So if you think someone has potentially dermatitis herpetiformis, what should you do? Should you check a serum IgA tissue transglutaminase, epidermal transglutaminase, do this indirect immunofluorescence, or a skin biopsy? And actually the best test is a skin biopsy for this test called the direct immunofluorescence, the one that I showed you that was lit up. So we usually do a regular biopsy and also do this perilesional biopsy. And this has the highest sensitivity and specificity. And one question, a lot of patients will come in and maybe have researched and think that that's what they have, and they've avoided gluten. Well, even if they've avoided gluten, it can be up to 13 years of avoidance of gluten that this test will still be positive, that IgA sticks around for a long time. So this is our best test. The IgA is also not affected by steroids, dapsone, other medications. So this is highest test. I only check serologies if there's some equivocal nature to the DIF. You can also do serologies to monitor their adherence to the diet because all of these fluctuate with their diet. So the ELISA for the tissue and epidermal transglutaminase, the indirect, but you have to ensure that they don't have an IgA deficiency, because if they do, then all these tests will be moot. So gluten-free diets are easier than they used to be. There's a lot of gluten-free foods out there now, but it is very difficult for these patients, so I always refer them to a nutritionist. Dapsone is one of the few satisfying medications in my career that works within 2 days. These patients will actually have almost immediate relief of their itching. It does not treat the neuropathy, and we don't know what it does to the risk of lymphoma in patients with celiac disease. We check a G6PD and we start low and work our way up. And it's actually a very effective treatment for dermatitis herpetiformis. All right, another itchy rash. This was an 83-year-old man who came in for a rash for about 2.5 weeks on the waistline and the ears. He did have recent arthritis and new CHF diagnosis. Past medical history, coronary artery disease, hypertension, hypothyroidism, remote myeloma. And this is what he looked like. So this is his waistline. Biopsy, special stain. Okay, so what is our most likely diagnosis? Henoxaron line purpura, primary systemic amyloid, vasculitis secondary to RA, idiopathic thrombocytopenic purpura, or capillaritis. So this gentleman actually has amyloid. And this was his presentation that led to his diagnosis. So amyloidosis is the abnormal deposition of amyloid, and it can be in just the skin or a systemic condition, and there's multiple types. I'm going to focus today on AL, which is the primary systemic amyloid. And we know that this is associated typically with a plasma cell dyscrasia, and these fibrils are typically composed of monoclonal light chains. This is typically of older men, and approximately 10% of these patients have multiple myeloma. So what organ system is most frequently affected by primary amyloidosis? Is it the skin, kidneys, heart, liver, nervous system, or musculoskeletal? So kidneys and liver are about the same, about 70% of the time. Skin's only about 25%, the heart is 60%, the nervous system about 15 to 20%, they can have a neuropathy. It can involve musculoskeletal, so there's the shoulder pad sign where they get deposition in the muscle. They can have an enlarged tongue, and they can also have a bleeding diatheses. So when someone presents with systemic primary amyloid, they typically have multi-organ involvement. Kind of a classic scenario is carpal tunnel syndrome and an enlarged tongue. But the cutaneous signs, which are really interesting, is actually that you get the amyloid deposition in the skin, and it makes the blood vessels very fragile. So any kind of Valsalva maneuver, they can actually get what we call the raccoon eyes around their eyes, and then pinch purpura. And they can also get just waxy thickening of the skin. And this patient actually had systemic amyloid causing his arthritis and his CHF. So upper left, pretty severe case. Bottom left is, you can see the indentation from the teeth because the tongue is so large. And then we have a very dramatic case of the raccoon eyes there on the right. This patient, this was all he had. It was his waistline, and this was just the pressure of wearing pants that caused this. So again, when you think about vasculitis and other things, they typically start on pressure-bearing areas like the lower legs and spread up. This is just not a typical location to have petechiae and purpura. So which sites have the highest yield if biopsied? Skin, kidney, abdominal fat pad, rectal, or bone marrow? So kidney is actually the highest yield, but less invasive procedures are typically utilized, like the fat pad. Skin as well and bone marrow can be used. So on a biopsy, you get these pink eosinophilic masses in the skin, and then the Congo red stain with the apple green birefringence is what you see on pathology, which I'm sure we all learned as medical students. So this patient, care was coordinated with all of his different specialists. He was treated for multiple myeloma. He died 18 months later from his disease. Okay, this is my last case. It has a more happy ending than some of my other patients. To be Debbie Downer this morning. Okay, this was a 68-year-old woman who was actually referred by her PCP for acne treatment. She had new severe pimples for several months. And that's makeup on top. It's not part of the rash. All right, so what should be my next step as her dermatologist? Should I prescribe doxycycline, isotretinoin, spironolactone or send her right on back to her PCP. So also, she's had a lot of hair loss and facial hair growth. That's really progressively worsened over the last year or two. This is her scalp. This is her chin. All right, so for all you astute test takers out there, you can see which one I added, which additional test. So I actually just decided to order some blood work. I thought I could send her back, but I thought, you know what? I'm going to figure this out. So what should you order? Just all of these or some of these? Total testosterone, free testosterone, DHEAS, prolactin, the ones below. Okay. So she actually did have a full gamut of lots of blood work. Prolactin was normal. Her DHEAS is slightly elevated. But you can see her total testosterone is 539 with an upper limit of 32. Free testosterone was elevated. So she went on to have a CT scan with no adrenal masses. And then she went on to have a oophorectomy and was diagnosed with a Leydig cell tumor of the ovary. So a very interesting case. So hirsutism. We get asked about hair loss and excess hair all the time in dermatology, and I think you all probably do as well. But the most important thing is to take into consideration their ethnicity, but also the pattern. So this was a rapid progression and severity in this patient. And then the androgens that lead to excess hair, you have to think about the source. So testosterone is usually ovarian, DHEAS is usually adrenal, and then androstenedione is adrenal or ovarian. And in postmenopausal women, there's really two major causes. So they can have an androgen-secreting tumor, which can be in the ovary or the adrenal gland. And with those patients, they're going to have an elevated total testosterone and DHEAS. And this is more of a rapid onset. So with this patient, she had a rapid onset of 1 to 2 years. The other condition is called hyperthecosis, and this is just an excess testosterone secretion by the thecal cells. This is more slowly progressive and maybe in the spectrum of PCOS. And so for me, to make things simple for my residents and for myself, if a postmenopausal woman presents with really I'm concerned about hyperandrogenism, the two tests that I want to order are total testosterone and a DHEAS. You can get a serum prolactin, but it's a very rare cause to be a problem. Free testosterone is more sensitive, but it actually has to be sent off to a special lab. And then the 17-hydroxyprogesterone is really only relevant more if you're thinking about premenopausal, because that can be a 21-hydroxylase deficiency. So we do have a happy ending, sort of. Her acne got better, but her hair loss and hirsutism were unchanged. But when she got that removed, her total testosterone went down to 25. And so we'll see if her hair loss and hirsutism improves over time. And that is actually my last slide. I want to thank you all for having me today. Feel free to ever email me. I love seeing complicated patients, and I work with the residents. And so if there's any kind of patient concerns that pop up, feel free to contact me today. So thank you very much. Do we have any questions? A couple minutes?